faculty host who nominated the visiting scholars. And I see some of the familiar faces here who have hosted the scholars. And the purpose of this program is to support CIRA and Yale faculty members to bring their international research partner to Yale for a short visit. And that's when they get to meet, to have some work meetings, to connect with other CIRA community members. And also we'll follow up the progress and the output of the collaboration throughout the next 12 months after the visit. So you can see in the blue box the scholars, countries, so we've hosted a number of people coming here throughout the past 10 years. And this is my last slide. So this is our team is small but mighty. So this is really a team effort. We have Dr. Luke Davis, who is the International Research Faculty Lead, who provides an oversight of the overall program implementation and evaluation. And there's me. And then we also have Liz Capello, who helped with the travel arrangements, access to CIRA, and then the Yale resources, and also Pete Donahue, who's also here in the room, who helped with the event promotion website, the CIRA newsletter, and the Zoom logistics. And with that, I'll pass it on to Luke.
Thank you, Denny, and thank you, Liz, and thank you, Pete. This is truly a gem of the CIRA program, and I know that many folks in the room have served as mentors in the past, and it's a really important event that we do every year. My background and my role here is to introduce our visiting scholar and faculty host. And I'll start by introducing Dr. Natalia Shumskaia, who's the director of the Public Foundation of Sooluk Nuru from Kyrgyzstan. Dr. Shumskaia is a trained psychologist and a goal-oriented, highly motivated research manager with over 25 years of research experience working in multiple projects with people who inject drugs and also people with HIV. She directs the public foundation called Sooluk Nuru, and you're going to hear a lot more about that today in Kyrgyzstan, where she collaborates with several Yale investigators. And from 2019 to 2022, she was the local principal investigator of a pilot trial in Kyrgyzstan, which led to the development of a specialized program called HOPE. HOPE stands for Help OAT Prison Engagement, which supports linkage to opioid substitution therapy among prisoners with a history of heroin injection use. And she works in close collaboration with Dr. Yulia Razanova, who I'm going to introduce in just a moment. The successful implementation of this trial and the resulting database report were highly praised by the prison service leadership. And this really exemplifies the type of thing that we think about in terms of community engagement and partnership that's so important in implementation science. And she is currently MPI with Dr. Rozanova on an R01 study involving a full-scale randomized controlled trial of the HOPE intervention in Kyrgyz prisons that was launched in August 2025 with funding from NIH. We're going to hear a lot more from Dr. Shumskaia in a moment, but I would now like to introduce her faculty host, who's Dr. Yulia Razanova, who's an associate research scientist in medicine in the section of AIDS in the Yale School of Medicine. And Dr. Razanova received her doctoral training in sociology of aging from the University of Alberta and conducted her postdoctoral research in social gerontology funded by the Canadian Institutes of Health Research at the Brown School of Public Health. At Yale, Dr. Rozanova's work was shaped by mentors in urban ethnography, psychiatry of resilience, and HIV prevention and addiction treatment. And I know Rick played a big role, who's with us today. Julia's research aims to develop, test, and bring to scale effective, bespoke interventions to improve clinical outcomes, longevity, and quality of life of older adults. Her current work focuses on management of multimorbidity, progression over the course of aging, and is specifically focused, of course, on people with HIV and addiction in the community and in prisons. And methodologically, Dr. Rozanova has great expertise in clinical trials, implementation science, and qualitative designs. She's published many articles, many book chapters, given many keynote talks, and has helped develop this wonderful collaboration with Natalia. So maybe just before we hear Natalia's presentation, I wonder if you just say a little bit about how this partnership came together, how you all first met and got us to this point. We'd love to kind of hear that since it's such an important part of the Visiting Scholars Program.
Well, thank you so much, Luke, for this wonderful introduction, and many thanks to CIRA for making that possible. for us to have that opportunity today. So we met through my senior mentor, Dr. Keltis, and it was all thanks to him that it happened. I started my postdoc with Rick in 2014, and then in 2015, I came with him to a conference on prison health that was held in Bishkek, in Kyrgyzstan. So even though like I'm originally from that region, not from that country, I never visited Kyrgyzstan before, and I never was engaged in prison health, and any of that was completely exotic. That's probably the best word to describe it, and rather frightening to me. But I was very curious, and so when I came with Rick, Rick is extremely generous in sharing his connections, his wisdom, his networks with his trainees and colleagues, and that's what happened with me. So he took me to meetings that he had with all kinds of folks in Kyrgyzstan that he knows a lot of people. And so one of those meetings was with Natalia and her colleagues in the organization that was then not then Sooluk Nuru, it was a different one. She will tell us about that. And I just thought, what a wonderful group of people, how welcoming they are, how easy it is to learn from them and just to be with them. So I thought it was fun. And then from there, it started for me that, by the by, I became a little bit involved with some other activities that were happening in Kyrgyzstan. It was all through Rick. And, I came another time, and then one more time, and then another time after that, that it was, with regards to projects that other people designed. And so I got to know a little bit more of the style of collaboration, of sort of like how you how you roll with these people, what are the key needs and what are some of the key problems that they're working on. And I was very inspired by that. And so when I was having a decision to find the location for my own career development awards, the first one was Patterson, so it was from the American Medical Foundation. And so there were other countries where my work would potentially happen. So Ukraine was a much more kind of obvious choice. And then the next was Moldova, but somehow, just I thought, well, I'll select Kyrgyzstan. Rick supported that. And so then I rolled my first project that was like an exploratory work before that trial that was piloted later as part of my KO1. And then, once I started coming more directly to collect, or to oversee the collection of my own data, then I got to know more of the local stakeholders as well. And so I think that my pathway of working with Natalia has always been guarded by the guardian angel who was Rick. And so I really owe it to his mentorship, the ways that we could connect. Because I think that the resources he provided, both in terms of funding that could launch those initial trips from his grants, but also the mentorship that he contributed to choosing the research questions initially, they were extremely pivotal. And I think that they shaped the course of of my career in a big way. So I believe that there is a link with the Asian world, with the deeply seated, deeply rooted cultures, not just in terms of the, scientific endeavors, but sort of like in the spiritual way with that part of the world. I'm not from there, so I can't claim any heritage. But when I saw the mountains and when I was able to spend a little bit of time with the local stakeholders and, kind of soak up some of that culture, I feel that all of that makes me a better person. And so now I'm very much humbled and inspired by us working together with Natalia. She's an incredible scholar and collaborator, but also a gifted diplomat. It's not an easy time to do global health work, and it's not an easy time to do work in prison and also in that specific region. And thanks to her, we're navigating those complexities. And I think that we turn challenges into opportunities. So I hope that we will have many more productive years. And again, huge shout out, huge thanks to Dr. Altis, who has launched many, many careers of a lot of people. And I'm thrilled that we're able to keep working together, because on all those projects, he's been my mentor and he's been the presence sort of behind all of that. He stood by me and by us all the time. So I look forward to Natalia's presentation.
Thank you, thank you. That was a wonderful tribute. So just before we get started, I'll just let everybody know, I think Natalia's going to speak for about 40 minutes. We'll have a chance for questions and answers in the beginning. For those who are online, feel free to type your questions in the chat and we'll take those at the end. And then after we get done with the Q&A, we're going to have some lunch here. So we hope you'll stick around to chat and get to know Natalia a little bit better. Please go ahead.
Let me just hide you. The thing there. Oh. Okay.
Well, good morning. I would like to thank everyone attending our meeting in person, as well as those who have joined us online. I often have the opportunity to present the result of a team project with our organization. However, I have never before had to deliver a presentation that required me to speak a little about myself. Interestingly, while preparing for this meeting, I realized that the story of my career coincide with the onset of the HIV epidemic in our country. As it happened, my professional growth as a specialist, expert, researcher took place specifically within the field, this field. Nevertheless, I would like to begin with a few words about our country. The Kyrgyz Republic is located in Central Asia, bordering Kazakhstan, Uzbekistan, Tajikistan, and China. Our country's capital is Bishkek, where I have lived for the past 21 years. Prior to that, I lived in south of the Kyrgyzstan, in the city of Osh, a city that is remarkable over 3,000 years. So, welcome to Kyrgyzstan. We'll go together to my city. Well, the country has a population about 7 million, and defining feature of our nation is that more than 70% of its territory is covered by very beautiful mountains, specifically the Tian Shan mountain range. Well, and I would like to say a few words about our organization that I represent. In the past, our organization operated as a branch of the international organization AIDS Foundation East West, with headquarters in Amsterdam. And then in 2013, when our headquarters informed us that they unfortunately would no longer to find our their programs in Central Asia, we re-registered as a local organization. Naturally, we were concerned about whether we would be able to secure funding of our organization. Fortunately, however, all donor organizations continued to collaborate with us, and in 2024, we were required to undergo re-registration once again and revise our organization statute in light of the new law on foreign agents. We removed from our charter any activities that could be potentially be constructed as political activities. And now I'm focused on supporting the public health system in the implementation of national program addressing HIV, TB, hepatitis, and other related issues. Our key areas of activity for today are continuous access to HIV service for migrants from key population, case management for people with TB at risk of treatment interruption, tracing and re-engagement in care for people with TB, reintegration of released prisoners, and research activities. Well, a few words regarding the current HIV situation in our country. On this slide, you can see the HIV care cascade. To date, 14,000 cases have been registered. The estimated number of people living with HIV in our country is 13,000. Of these, nearly 82% know their status. 71% are receiving ART, and 90% have achieved viral suppressions. As you can see, our country has not reached the WHO recommendation 95 targets. HIV is detected primarily among the 20 to 38 age group, accounting for 61% of all registered individuals with HIV. Men predominate among those with HIV, making up 63% of the total, while women account for 33%. A proportion of women that continues to increase year by year. Over the past 5 years, newly diagnosed individuals with HIV, the proportion of cases transmitted sexual increased from 81% in 2019 to 90% in 2025, while the proportion transmitted via injection declined from 12.6% in 2019 to 2.4% in 2025. This slide presents the results of the IBBS regarding HIV prevalence among key population groups. Specifically, the estimated number, for example, of sex workers is 9,300, with a prevalence rate 4.4 in Bishkek and 3 in Osh. People using drugs, the HIV prevalence among people who use drugs 14, among MSM 10.7, and labor migrants, you can see it's around 1%. Let us look at the HIV situation within prison system. On the left side, you can see that the number of people living with HIV in prison is gradually declining. On the right side, we have the HIV care cascade. Since every inmate undergoes HIV testing upon entry into the prison system, and subsequently on annual basis, we know the exact figures is on April 2026. There are 138 individuals, and 95 are on ART, and 90% have achieved viral suppression. As you can see, the situation in prison system is more favorable than in the general healthcare sectors. Currently, various HIV prevention programs among people using drugs and implemented in the Kyrgyz Republic. This includes testing and counseling service provided both in medical facilities and through non-governmental organization. Program facilitating access to sterile syringe and needles, which implemented by a non-governmental organization in our country. Doctors from the aid centers, in collaboration with non-governmental organization, frequently visit public gathering places such as markets and truck stops to conduct group counseling and perform rapid HIV testing. The PrEP program could be described as more successful among MSM communities than among people who use drugs. nevertheless, work is continue. And just a couple more slides regarding the methadone program. Is our research, which I will discuss a little later, is directly or indirectly related to it. In 2000, of the Ministry of Health of our country initiate in order to develop a methadone program. Then regulatory and legal frameworks were established, and in 2002, a pilot program was launched in 2 cities and enrolled 50 participants in each. Well, on the next slide, you will see dynamic of official registered people using drugs and patients of OAT sites. The blue bars, this represents the official registered number of people who use drugs. The orange bars represent the number of clients who people who using drugs, people who are currently on the OAT program. And overall, we observe that the number of people who inject opioid is declining, resulting in corresponding increase the proportion of OAT patients. These graphs show a breakdown of the number of patients in prison versus in the civilian healthcare system. There are 526 people in civil sectors and 190 in penitentiary institution. So I hope you have a general overview of the HIV situation in our country. And now let's take a retrospective look at the history of the HIV epidemic development and how I became involved in prevention program. In 1996, the first cases of HIV infection in the country were recorded among foreign students at the aviation college in Bishkek. At that time, well, this didn't concern me at all. I had 2 small children and plenty of other things to worry about. I was working as a school psychologist, and in 1998, my former university professor called to me, and she told me that she was working on a project for the international organization Medicine Sans Frontiers, Doctors Without Borders, and that their team was in need of psychologists. And since there weren't very many psychologists in our city back, and then she thought of me and mentioned to her boss that she knew a practitioner psychologist. In short, I was invited to a meeting where I learned that, as it turned out, an epidemic of syphilis was on the rise in the southern part of our country, and that the HIV epidemic could soon follow. Well, they were preparing to launch the HIV prevention program among sex workers, and I was also invited to join this team. That time, they invited me to join as outreach worker and as a psychologist, and the team also included a nurse. We usually call them as expat of Doctors Without Borders team, and a sex worker who served as a peer outreach worker and the vital link between our program and the target group. Well, I began studying topics related to HIV, STDs, drug addiction, and harm reduction strategies with great interest. And my work involved having my first conversation with sex workers, building relationship based on trust, and assessing their needs and the problems they faced. Twice a week in the evening, we would go out to the place where sex workers gathered and walked to saunas, workers' dormitories, and so-called spots on city streets where groups of sex workers would stand waiting. Even back then, more than 90% of the sex workers at the time, they were working under control of PIMS. Well, and the first step was to approach to Madame, introduce myself, and explain why we are here, why we'd like to suggest them, and specifically that there was an opportunity for the women to get tested for syphilis and HIV free of charge. Well, and we would arrange a meeting time and then escort them to our friendly doctors. Additionally, on Saturdays, I conducted information session in the organization office hall. We adopted these coffee breaks. During our outreach work, we distribute flyers inviting people to these coffee breaks where they could, we invite them and we suggest them that they can be free, give any questions and enjoy coffee and some sweets. Well, surveyed our target group to find out which topics they would be interested in discussing during these sessions. And it turned out that no one was particularly interested in topics like syphilis, HIV. Instead, they were more interested in things like how to apply beautiful makeup, how to care for facial skin, and so on. Consequently, I proposed to our team supervisor that we start our training session as follows. The first part would cover topics of interest to the sex workers. For this, we would invite some experts, makeup, maybe artists, well, and they could provide some information, they can provide demonstrations, some practical, give them advice. And this would be followed by break for coffee, of course, and smoking, and after which I, alongside peer outreach worker, would conduct the second part of the sessions, focusing on the prevention of HIV, on safe sex, practical exercise such as how to use condoms, well, and related topic. And at the end of the session, those who wished to get tested for syphilis and HIV were given vouchers, referrals to our network of friendly doctors. Well, in 2001, Doctor Without Borders, they scaled back its operation in the Osh region, and the head of the mission suggested that I register a non-governmental organization to continue our prevention programs among key populations, and I followed to his recommendation. I registered a non-governmental organization named Podruga, and in 5 months later, in 2002, with the support of international donors, we launched a syringe and needle exchange program for women who use drugs. And I was one of the first outreach workers who goes to the place of living women who use drugs, and started to. That time it was really exchange. We should give them steel and take the dirty syringes. Well, and I'm really grateful to different donor organizations. That time it was really a good time, and donor organization support like these programs. They organize and hosted a vast number of trainings, seminar session for non-governmental organization, through which I was able to gradually build my professional capacity. I learned a great deal from international experts regarding methodologies for rapidly assessing the size of key population, designing programs based on the specific needs of a group, establishing partnership with both governmental and non-governmental organizations, and much, much more. Well, in 2004, UNAIDS, Regional Office of UNAIDS, for Central Asia, they invited me to conduct a rapid assessment of the sex worker population in Bukhara, Uzbekistan, and to develop an HIV prevention program for this target group in collaboration with the local aid center. It was my first international study and new phase in my research career. Well, as I have previously mentioned, in 2002, a pilot program for methadone maintenance therapy was launched in cities Bishkek and Osh. At the time I was in Osh. Me and my team of outreach workers, we encourage people who use drugs to enroll in this program. Well, in 2005, I became the head of the Kyrgyzstan branch of the international organization AIDS Foundation East-West, AIDS Foundation East-West, and our initial HIV prevention program was implemented in 2 prisons of our country. We conducted seminars for inmates, and it is worth noting that the leadership of the State Penitentiary Service was open to collaboration and actively supported our HIV prevention efforts. At that time, nearly 1/3 of the inmates were people who used drugs, and of course, creating a high risk of HIV and hepatitis transmission. In 2007, 2008, a new problem arose. More than 200 cases of hospital-acquired HIV infection were registered among children, and the parents of these children showed hostility towards medical staff and refused to give their children ART therapy. And with support with UNICEF, our organization opened a social bureau, social support center in the city of Osh, specifically for families affected by HIV. The center was staffed by coordinator and psychologists. They provide consultation, seminars for both parents and medical professionals. And as a result, positive deviance champions emerged. Parents who were the first to agree to ART for their children, and they went on to serve as peer councils at the social centers, and this way an increasing number of parents began to place their trust in the doctors and enroll their children in ART treatment. In 2011, I had significant meeting with Dr. Frederick Altis, who proposed a collaboration that led to the first randomly sampled nationwide behavioral health survey, which was conducted in 8 prisons in Kyrgyzstan among all soon to be released prisoners. And I considered it a distinct honor to receive a collaboration offer from a doctor of the Yale School of Medicine, one of the most prestigious and top-tier academic institutions. And my specific role was to organize the field work component of the study, which involved screening prisoners for HIV, syphilis, hepatitis. Thanks to my prior experience, in implementing preventive health program within correctional facilities, we were able to organize every aspect of the study in the most effective manner possible at that time. And study revealed that 49.7% were infected with hepatitis C, 19% with syphilis, and while 10% were with HIV. It is worth noting that I was afforded a remarkable opportunity to learn from Dr. Altis specifically how to conduct focus group, how to formulate the right questions, how to practice active listening, and how to negotiate with key decision makers. I remain infinitely grateful to you, Dr. Altis, for these invaluable lessons and for the wealth of experience I gained as a researcher. Currently, we are implementing a project titled Expanding Medical Assisted Therapy in Central Asia, and our aim is to develop improved sustainable models for OAT deliveries that are contextually relevant, including the integration of AT service into primary healthcare and HIV clinics care settings. Well, me and my colleagues on a monthly basis, we conduct coaching sessions with our OAT site-based teams. We facilitate the process of defining SMART goals. We use different techniques such as nominal group techniques. Well, and in 2024-25, in 2024 and 2025, these objectives include increasing the provision of adequate methadone dose and improving hepatitis C screening. And on the next slide, you can see the impact of our intervention. The figure in the top right corner illustrate an increase in the number of patients receiving the recommended dose. And here you can see hepatitis C cascade in prison sites of OAT. All of them screening on hepatitis C, and 58% of it was confirmed, and 94% of them started their treatment. Some of them already completed treatment. Some of them are under treatment. This cascade show in sites of primary health facilities. Little bit less, but anyway, it's really a good results because it's now more on systematical base. All patients of OAT sites is screening on hepatitis C. Well, I would like to turn to the HOPE project study, and as Dr. Yulia Rozanova already told story how we can met each other. Well, I on this slide you can see a big list of all researchers who work in this project, and you can see researchers from the US, from Ukraine and Kyrgyzstan. In the photo, you can see our Kyrgyz team. for the pilot project. I would like to dwell briefly on the pilot project. We went through a preparatory phase that involved interviewing inmates, identifying key barriers and core messages, developing program models, conducting pilot runs, training and preparing our facilitators and organizing the intervention itself. But then there was COVID-19, it just postponed a little bit, but when we started our activities, it also introduced which introduced its own set of adjustments, such as requiring facilitators, for example, and researchers to undergo weekly testing before being permitted to enter the panel facilities. Well, our intervention is information session, 12 session, to develop skills for a healthy lifestyle, psychological well-being, value-based attitude to health during incarceration, and preparing participants for goal setting after release. Well, HOPE enhances skills for management of opioid addiction to allow prisoners to live more fully while minimizing HIV risks. HOPE session address 6 domains: self-acceptance, autonomy, stress, regulation of emotion and feelings, positive relationship, goals in life, personal growth, and managing the surrounding environment. Well, each session has a mini lecture by clinical psychologists and questions, answers, discussion, and group skill building activities, which facilitated by peer expert by experience. Well, usually 15 to 20 people participate in a group, and it was also homework. Homework included answering open-ended questions, applying what they have learned to their life, and keeping diaries to note their perceived achievements. Well, thus we have received confirmation that improving mental health is a crucial element in fostering a positive attitude toward OAT therapy. This slide features a photo of a letter of appreciation that the training participants created themselves by hand, such as beautiful frames, such warm words of gratitude, and our team was delighted to receive such feedback from the participants. Well, main results of our piloting HOPE in Kyrgyzstan: 96 male prisoners with heroin injection history. They recruited across 2 Carceral and 2 HOPE prisons. We use generalized anxiety disorder screen, patient health questionnaire, and brief resonance scale, and all these screener showed better in Carceral prisons as baseline. Well, we conducted 12 sessions during the 6 weeks, and it was basement surveys and intervention. After that, in 3 months, 6 months, and 12 months follow-up surveys. On this slide, you can see baseline demographic health and psychosocial characteristic of participant by study. Well, we saw a trend toward higher OAT uptake. About 11% of HOPE participants initiate OAT, compared with 2.3% in the control group. This was not statistically significant due to the small size, but it's promising some signal. Well, In adjusted analysis, 3 factors independently predicted better mental health at 12 months, being in the HOPE program, the implementation context, sorry, it's about life satisfaction score. Like the experiment group showed a notable improvement, scoring significantly higher, 26, than the control group's 20, with a significant difference. And patient health questionnaire also showed a significant improvement in depression symptoms compared to the control group. And brief resilience scale also showed significantly higher resilience compared to the control group. In adjusted analysis, 3 factors independently predicted better mental health at 12 months, being in our intervention in HOPE, then the implementation context, or we can say prison type facilities, and having children. This tells us HOPE helps the environment matters a lot, and family connection may bolster well-being. Why does this matter? Because prison critical HIV prevention sites, and HOPE shows that the psychosocial empowerment can strengthen engagement with OAT and resilience, closing important gaps in prevention in higher risk prison settings. Also, OAT uptake prevents HIV transmission. These remain low in prison due to compounding barriers such as stigma, criminalization, and lack of psychosocial support. People in prison prefer interventions that boost overall mental health with addiction management and reduce the risk of HIV. Well, and some more interesting findings regarding alcohol consumption. In experimental group, overall audit score is lower at all follow-ups than in the control group. It is statistically significant. Well, the total audit score is not different between groups. For other variables, while our sample is too small for power, there is a signal that fewer people in the experimental group have increasing risk of hazardous alcohol use at amongst 12 than in the control group. Maybe then Dr. Yulia can.
Do you want me to jump in? Хотите, чтобы я сейчас сказала такой вопрос?
Может быть, я тогда закончу потом.
Давайте.
Thank you. Well, why has HOPE worked? Because this intervention provides space for reflection, discussion, and skill practice, countering the monotony and social isolation during incarceration. The information session was provided by a pair of psychologists and peers, and it also created credible empathic learning environment and psychoeducation on stress management, emotion regulation, and goal setting, strengthening self-efficacy, leading to behavior change. Well, and HOPE may catalyze readiness to engage process that could yield measurable increases over longer follow-up or after release. And participants with children experienced higher life satisfaction at follow-up, maybe we can also study this point, like children, it means stronger motivation to be well. Well, and in general, participants enjoyed on this our sessions. Well, I would like to conclude my presentation at this point and express my gratitude to Dr. Yulia Rozanova, who constantly inspires me and at times believes in me even more than I believe in myself. She granted me this unique opportunity to participate in the CIRA program, to meet all of you, to exchange experience and share my personal story. So publicly, something I had never done before. My thanks also to go to the CIRA team, Dini, Elizabeth, and Trace. My gratitude to my colleagues, my team in Kyrgyzstan, Dinara, Margarita, and Rizkul. Thank you that you joined at so late time. Well, thank you to all of your attention. I invite you to visit Kyrgyzstan, and I will be very happy to meet you and show you our very beautiful country and nature. Thank you.
Thank you very much, Dr. Shumskaia. That was a wonderful presentation, and it was wonderful to hear how your work has evolved over the years. So we'll open it up for questions. Denny, do you have the ability to check for questions in the Zoom and folks in the room? Maybe I could start with the first question. I'm actually personally very interested in these peer-led approaches, and you described a lot throughout the course of your career where you've taken approaches that were, I would just call them holistic, maybe rather than biomedical. Could you talk a little bit about where that came from, and also what was it like to introduce those things? Because it's probably somewhat different maybe than traditionally how people have approached, maybe more a biomedical approach being more common, I would guess. Did you have any challenges getting people to accept this idea that you would focus on well-being through things like the hope or the story that you told about working with the sex workers and kind of emphasizing things other than kind of public health prevention? Could you just talk a little bit about how well that was accepted by your colleagues?
My colleagues told me that I am crazy. Because I worked at school as a school psychologist, and it was like, turn to another, you can say, public health sector. It was new for myself, of course, and I cannot say that many people support me in this idea, and because high stigma toward sex workers and people who use drugs, it's like transmits to you too if you work with them. It's also concern you too. Well, and but I was much younger, and I was going to into second stick. It was very interesting field for me because I would like to know about how I can assist, how I can change the behavior from the risk of HIV, risk behavior to more safety. Well, and that time it was a new program. I mean, when I started, when I was involved in the prevention HIV program in my small town, and it was, I cannot say that I discussed with my some colleagues because it's not so many of us at the time, and I was supported by experts like Gulnara Kurmanova. At the time, she was leader of NGO Ties Plus. Ties Plus, the first organization who started their work with sex workers in Bishkek, and I was supported by her. She also, I can say that my first teacher shared openly with her experience approach how to organize prevention work with because, you know, give information, of course, it's not enough. When we organize coffee breaks, we told about what has been HIV, the ways of transmission, and I was so naive. I told that when I conduct one information training, and then everyone will use condoms. Well, but then they came and say, Natalia, I should go to the doctor. Syphilis, gonorrhea, and I told, well, and I was supported by more professional people in this field. Well, and I wasn't supported, for example, by doctors. I mentioned that it was just too friendly inequalities or involved in this partner network of friendly doctors, while others, but with state penitentiary services, it's another story. As in 2005, it was my first visit to prison of Kyrgyzstan. That time they were very open because the situation with HIV was very, very dangerous, and they really tried to do something because that time they didn't have any resource, and they were very appreciative to any donor support. I think we could collaborate with them, and they really appreciate. I remember that when we presented the result of this survey, it's really shocking. 49% of people with hepatitis 19 with 10% of HIV. When we presented on our national round table, and you know, Dr. Altis again, very patient. Donor organization, international organization, our Minister of Health, they really realized that it's a very serious situation, and they started to funding programs to fund prevention of HIV. And about hope, by the time we already have some image, and it was more easier to start to work, and because in prison to organize some activities is not easy. We negotiate with staff, non-medical staff, medical staff, social workers inside the prison, and they really help us conduct this. Я правильно?
Я могу сейчас просто еще чуть-чуть. So just something that I wanted to kind of add and make an observation. I did not know the story about Natalia's organizing the coffee breaks for women and how, you know, like beauty and makeup was the magnet for them to come and to enjoy themselves. And then other information was an additional piece to that. And I think that that is really the approach that is bespoke to Natalia, because she has this insight into what people will like. And that is so important. And that's exactly what we did in the Hope intervention, but it also was combined with my sort of like, that's her thing, you know, like doing what people like. My thing is that I have a very high degree of social anxiety when I can tell, you know, that like, I feel that the vibe in the room is bored, you know, like when I'm saying something and people are just like bored out of their mind, I cannot take it. You know, some other people might be okay and tolerant of that so that they can deliver a message that they believe is important. And, you know, the reception to that message doesn't bother them quite as much, but it kills me. Like I just am destroyed. And so for me, it was very important to find something that these sessions where I had to witness them, or at least some of them, wouldn't make me feel like I want to run away. And you can't run away from the prison because you're already there. So it had to be something that people would not like just look and say, what the heck is that? You know, like it's bad enough in prison, and now you come and it's just unbearable, just shut up, and so we have to find a product that would be useful, but at the same time that would be enjoyed as they were going through that. So something that might be difficult to do, that would require them to like do some soul searching and things like that, but that they would appreciate. They wouldn't reject because it's like completely unwelcome. And of course the messages about addiction are kind of painful messages, so not everybody wants to take that. It's sort of like this spoonful of sugar makes the medicine go down. So that's the approach. And another part to that, which I want to highlight, which you saw in Natalia's presentation, is very important. Like the children's presence and all of that, that was connected as we analyzed the data with their good behavioral patterns that led to them choosing addiction management. These people had children before we came. Some of them had grown children. So these were like 50, 60-year-old men whose children were like 30 something. It's not like that they had children while we were there, but they never thought that children matter that much, or they didn't value them. It never occurred to them that it's an important part of their life. So the fact that our intervention was able to like engage them with what already existed, even though they were in prison and they thought, well, whatever, like I have some children somewhere, big deal. It became a big deal to them. And it became something that they thought, oh, well, now I feel better about myself, my life, what I've, done with my time, and maybe I should take care of myself. And so these are all examples of, how some small thing that, it can be a very tiny message, or it can be a small interaction, or it can be even that they were looked at by their peers within that group with a different sense of respect because they were fathers. And so, they kind of could be elevated by the, public opinion within the group of those peers that, we intervened with. So all of those things mattered. And I think that, those 5 people who started treatment, 6 in control group and 1 in the, 6 in the intervention group and 1 in the control group, like 5 more people than, it would have been without us. It's kind of a lot, because all these people are, somebody's father, son, brother, potential boyfriend when they get out, or even while they're there. And so, this is an impactful process, and all of that starts with, thinking about what do people like doing, not like what they should be doing because they need to change their behavior and, go on a diet and stop doing this or that, but what do they enjoy? What is it that is easy for them? And they can really like do it right now without any kind of effort, for that matter. And Natalia is amazing in being able to just identify that. And I think, I'm not sure if you can teach that from scratch. You have to feel it. You have to be able to observe people and understand, what it is for that group that they like doing.
What a wonderful tribute.
That's very good. The thing that was, I thank you for a wonderful presentation, and kind of to both of you. The thing that really struck me the most about what you presented was you picked up on the interest in beauty for the sex workers. And I was
They
thinking,
told me.
but that is so critical to a harm reduction philosophy of, and you sensed it and you understood and were able to embrace it, that you meet people where they're at. And you're saying the same thing, that clearly, it's philosophically, I don't agree with you that people can't be taught harm reduction philosophy and learn to embrace it. But you too well, it's like, I don't believe that psychotherapists either, are born psychotherapists. I think you can teach skills to people, but clearly the two of you understood and got it about harm reduction and meeting people where they're at and bringing them along. And bravo to you both.
And I would just point out over the longer arc, her special gift is actually seeing the Venn diagram where 2 groups come together, whether it's the people who are doing the intervention and the people in prison. I will also just say that, you know, over this long arc and your story about the makeup put it together for me. And it's about, and you use the word meeting people where they're at, which is exactly right. But it's the idea that when there is a tension that happens between what one group is trying to do and people who are trying to take it on, if you can find that common ground, which is, I think, your special gift, and I'll just give you one other example. We do collaborative work with addiction treatment people in all of the sites and the people in the prison and stuff like that. And, you know, the first time we came in, they thought we were a unicorn. What did she do? She had everybody, she had these opening little things that come up. And she brought us all together. What the kernel she found was, and, you know, and Yulia pointed out a little bit, was that everybody there has families. And so you bring up something. So your opening thing where you got this tension, and I call them icebreakers. She's so good at it, but it's an icebreaker in terms of the design, it's an icebreaker in terms of how to engage and stuff like that. And that's a special gift, because as Luke's first question was, is, you know, you come in with your biomedical, you know, intervention and prevention, and you just want to implant it. You spent a lot of energy, you spent 300 hours writing your grant, and you know what you know until you get into the field. But this is the special gift.
Actually, the other thing that she said, and that you've brought up too, is for future research, what you found was it wasn't necessarily marital status, which is something we collect all the time, but it was about the things like kids, and that you have picked up on something that is potentially very novel in looking further into, you know, the power of having children, if you're lucky enough to have children,
And
can help with promoting behavior change.
And also, I mean, we didn't ask, like, do you have nephews? Because that's another thing, right? Like, a lot of those people come from many, like, you know, siblings, where siblings are available. So even if, for example, they never had children themselves, they can have nephews, which are very important, you know. And so it's one thing that, you know, we just never included into our survey, but we will in the, you know, in the R1 side.
So Sheila has had her hand up, and then there's one question on Zoom. Sure, yeah. So the question is actually from Dr. Claire Pogala, who is our international visiting scholar coming in June. So her comment was, well done, Dr. Shumskaia. What were some of the barriers to the uptake of the OAT according to the participants?
Какие барьеры для того, чтобы начать терапию метадоном со стороны, ну, то есть как бы сами заключенные, что они...
терапию, но не участие. Well, it's still a high stigma to OAT because when OAT program is introduced in our country, I think it was along some message from to start this program, because they promise people that this program it has some period, that they will over their addiction, that all of them, if they take methadone, then step by step they will decrease their dose and they will sort kind of.
They were promised a cure within 6 months.
Yeah, absolutely.
Okay.
Cure them. And after people realize that no, it's impossible, because some of them really, I remember when I was at time in Osh, some of them started and from the high dose and decreased and went out of the program, and just in some, I don't remember exactly, maybe 1 week, it was overdose. People died, people died. And at that time, experts started to try to change this message and explain parents. It was Parents also more resist to this program of drug users, and we explain them how it's important to save their lives, and it's legal, it's not illegal, blah, blah, blah. And parents say, look, the idea that their child, they will be so cured, cured. Well, they never use drugs. Well, and it's one, I think it's like, it comes from the beginning. Well, and second idea is that it's a stigma inside of the group. If you are okay, if you have money, you can buy drugs. But if you are not, you will go to this program. It's like hierarchy between themselves. So you are not so good. That is why you are well. And the main problem still is our team in collaboration with the public, and we try to increase knowledge about adequate dose for medical professionals, medical staff, or even for IT sites, because they also have like this, attitude that not necessary to increase. It's better to decrease dose, but if they don't have, don't receive adequate dose, it means that they try to use some another drugs, especially in our countries, they use dimidrol.
Diphenhydramine.
And it's really hurts, and it's very bad to their health. And it's also, people who see clients of internal programs that are not very well because they fully drug users, and yes, they use very in bad ways. They just buy these pills, crush them, and add the water and put of course it's a lot of lipids. Well, it's some problems. It's still stigma. There is no, but we try to use all of that. But now we increase a little bit level of patients who owns adequate dose higher than 80%. And I would like again say to thank Dr. Altis who advocated our clinical guideline. It was just 40. Yeah? Now it's 80 milligrams because it's liquid. Well,
I comment on the registration,
Ah.
what the restrictions are, and the complexity of the induction. That's the other thing the patients say.
Yep.
and registration, official registration is also one more year.
You could lose your job.
Yeah. So I think Sheila has a question. Yeah.
And I think you said another barrier that we were talking about the other day was that if you are formally registered, that you can't work in the prison.
Yes, yesterday.
This is a major
The reason now,
Current.
there is change. It's some, we can say, policy reform inside the prison, and recently we conduct focus group, in-depth interview with released prisoners. And what we what information we received from them that now we can say more than 90% of inmates they work. Before it wasn't any
There was an opportunity.
opportunity to work, yes. For the last 2-3 years, our government, they really give good budget for state penitentiary service, and they fund some businessman who started some manufacturers inside the prison, and people,
Oh.
prisoners now walk.
Wow.
And they earn money even, they receive salaries before it.
That wooden frame you saw was created by them.
Oh, beautiful. I was noticing that.
Well, and between our clients operating programs, they exclude because this owner of this manufacturer, they told that it's very dangerous for them because safety
Regulations,
safety
yeah.
regulations, they use drugs.
Right.
And we again explain, doctor, medical staff tries to explain them that methadone, it's not give free or they are but anyway, they exclude it again. Some discrimination, it's also one of the barrier.
So that's a major deterrent for people being on methadone, right? Because then they can't work.
Can't work in
So, right, so I don't know, we were gonna talk with you about possibly like reframing methadone use as the safer option. right?
Yeah.
As promoting safety, for people who want to work.
We have worked it, so all countries of the former Soviet Union have got this thing in place where, one, you can't get a driver's license or you lose your driver's license,
Mhm.
or you cannot work in any kind of manufacturing type of work or construction, which is what most of these people are doing. So it's a disincentive, and I have to tell you that we have failed in every single country to get that law removed.
Mhm.
Because they want to count people. This is why they don't even get registered. So if you don't get registered,
Yep.
you can't get to medication. So that's like a major impediment. What's interesting is that countries like Ukraine have shifted it. And so instead of saying, yes, this person is on a methadone program, they don't do that. They just say, this person is safe to work.
Mhm.
That has changed the way that they've operated, but the law did not go away.
Yeah.
So Ukraine went from, we started early, but we're well over 30,000 now. And so this is a place where they were stuck at 8,000 until we started doing the same work and got them up to, 30, which is where they are today.
Wow.
And that's just in the government clinics.
Well, this is not the end of the conversation, but I think we are at a point where we need to let our webinar guests go. I'd like to just first give a big round of applause for the wonderful presentation and just for your work. Also to Yulia for playing host, and to Rick to sponsoring all this, everybody for being here. I want to thank the folks that are online. Denny, I believe that when people log out, there'll be a CIRA survey. So we just ask you to take 1 or 2 minutes to give your feedback to us, give any suggestions on future topics that you'd like to hear. For those of us who are here, we're fortunate to have lunch. So please stick around, mingle, speak with Natalia, and have a great rest of your day. And make time to meet with Natalia. She's here for 10 days altogether, so a few more days yet. If you'd like to get on her schedule, talk to Yulia, and she can help you set it up.
And thank you for CIRA for making global health important part of the work. Really wonderful.
Wonderful. Thank you.
Thank